Today, we're going to talk about one of the most valuable interventions we have available in pre-hospital medicine, non-invasive positive pressure ventilation. Specifically, we're going to look at CPAP and BiPAP, and more importantly, understand why each one works and when each is the better choice. As EMS providers, we often become very comfortable following protocols. We recognize pulmonary edema and apply CPAP. We hear wheezing and think about BiPAP if it's available. But if someone asked you why CPAP works so well for one patient yet may fail another, or why BiPAP is the preferred choice in certain respiratory emergencies, could you confidently explain the physiology behind that? That's really the purpose of this course. This isn't about memorizing another algorithm or simply knowing which button to push on a ventilator. It's about understanding what's happening inside the patient's lungs and how the pressure we apply changes their physiology. Once you understand that relationship, the decision of CPAP versus BiPAP becomes much more logical instead of simply following a protocol. We'll also focus on what matters most in the pre-hospital environment. We don't have laboratory values, chest CT scans, or respiratory therapists standing beside us. We have a patient, a physical assessment, our monitor, capnography, pulse oximetry, and our clinical judgment. To interpret those clues quickly allows us to choose the right intervention earlier, which often prevents deterioration before we ever reach the emergency department. Throughout the presentation, we'll work through real EMS scenarios that illustrate how different respiratory diseases create different problems. Some patients primarily struggle, while others primarily struggle to ventilate. Understanding that difference is the foundation of selecting the correct therapy. By the end of today's session, you'll be able to recognize which patients need CPAP, which patients benefit more from BiPAP, when each therapy can fail, and when it's time to move toward definitive airway management. Let's begin by looking at exactly what we hope to accomplish during this course. Before we discuss CPAP or BiPAP individually, let's establish the specific objectives we'll accomplish together. Every educational session should answer one simple question: what should I be able to do differently when I leave? These objectives are designed around real decisions you'll make during an EMS call. Our first objective is to clearly differentiate CPAP from BiPAP. While both use positive pressure and both can improve respiratory distress, they are not interchangeable therapies. Understanding the differences between them is essential because applying the wrong modality may delay improvement or even worsen certain conditions. Our second objective is understanding the pathophysiology behind these devices. We often hear phrases like CPAP improves oxygenation or BiPAP helps, but what does that actually mean? We'll look at what happens at the level of the alveoli, how pressure changes gas exchange, and why carbon dioxide behaves differently than oxygen. Third, we'll identify the patients who benefit most from each therapy. Respiratory distress isn't a diagnosis, it's a symptom. CHF, COPD, pneumonia, asthma, and mixed respiratory failure can all present similarly while requiring different treatment strategies. We'll learn how to quickly distinguish those patients using information readily available in the field. Finally, we'll apply these concepts to actual pre-hospital scenarios. We'll discuss what we see on scene, what we hear during lung auscultation tells us, and how those findings help us decide whether CPAP or BiPAP is the better choice. The goal isn't simply to make you more knowledgeable. It's to make you faster and more confident when standing beside a critically ill patient. Because in respiratory emergencies, every minute counts. Choosing the correct therapy within the first few minutes often determines whether the patient stabilizes or continues progressing toward respiratory failure. As we move forward, keep one question in mind: what problem am I actually trying to solve? That question becomes the theme of this entire presentation. Now that we've established our objectives, let's talk about why understanding these differences is so important in everyday EMS practice. Respiratory emergencies are among the most common high acuity calls we respond to in EMS. Whether it's pulmonary edema, COPD, pneumonia, asthma, or mixed respiratory failure, these patients deteriorate quickly if we don't intervene appropriately. Fortunately, non-invasive ventilation has dramatically changed how we manage many of these patients. Numerous studies have shown that early application of CPAP or BiPAP reduces the need for endotracheal intubation, decreases ICU admissions, shortens hospital stays, and, in certain patient populations such as acute cardiogenic pulmonary edema, even decreases mortality. That's remarkable. Few interventions we perform in the field have that kind behind them. But here's the catch. Those benefits only occur when we select the correct therapy. If we apply CPAP to someone whose primary problem is ventilatory failure, we may improve oxygenation slightly while allowing carbon dioxide levels to continue rising. On the other hand, delaying CPAP in a patient with flash pulmonary edema allows alveoli to continue flooding, worsening hypoxia and increasing cardiac stress. Understanding the physiology behind the disease process allows us to intervene much earlier and much more effectively. Another reason this matters is patient comfort and trust. A patient struggling to breathe is frightened. Applying positive pressure can initially anxiety if we don't coach them properly. Our communication, reassurance, and confidence often determine whether the patient tolerates the mask long enough for it to work. Finally, remember that non-invasive ventilation isn't replacing critical thinking, it enhances it. These therapies require continuous reassessment. We don't simply place the mat about the patient. We monitor respiratory effort, oxygen saturation, EtCO2, blood pressure, mental status, and overall clinical appearance. Improvement should be visible within minutes. If it isn't, our plan needs to change. Recognizing that early is just as important as choosing the correct therapy initially. Before we compare CPAP and BiPAP, let's begin with a simpler of the two devices by understanding exactly what CPAP is and how it works. Before we can appreciate how CPAP and BiPAP help our patients, we have to understand how breathing is supposed to work. Everything these devices do is based on normal respiratory physiology. One of the biggest concepts to understand is that normal breathing is a negative pressure system. Unlike a ventilator, your body doesn't force air into the lungs. Instead, it creates a pressure difference that allows the atmosphere to do the work. Think about using a syringe. When you pull the plunger back, you're not sucking fluid into the syringe. You're creating an area of lower pressure inside the barrel, and atmospheric pressure pushes the fluid in. Your chest works exactly the same way. The diaphragm is the primary muscle of breathing. When it contracts, it moves downward and flattens. At the same time, the external intercostal muscles lift the ribs outward and upward. Together, those muscles increase the volume of the thoracic cavity. Now remember one of the basic gas laws. When volume increases, pressure decreases. As the chest cavity expands, the pressure inside the lungs drops below atmospheric pressure. Air naturally moves from an area of higher pressure outside the body to an area of lower pressure inside the lungs. That's why we say we breathe by negative pressure. As the lungs inflate, oxygen reaches the alveoli, where it diffuses into the bloodstream, while carbon dioxide diffuses out exhaled. Once inspiration is complete, the diaphragm relaxes and returns to its normal dome-shaped position. The elastic recoil of the lungs and chest wall decreases the volume of the thoracic cavity. Pressure inside the lungs rises slightly above atmospheric pressure, and air flows back out. In a healthy person, exhalation is almost entirely. The body doesn't have to work very hard to breathe. Now let's talk about the work of breathing, or work of breathing. Every breath requires energy. The diaphragm, the intercostal muscles, and sometimes even the accessory muscles of the neck and shoulders consume oxygen just to move air. In a healthy adult, that workload is relatively small. The problem is what happens when disease changes the equation. A patient with acute pulmonary edema is trying to breathe through lungs that are filling with fluid. A COPD patient is pushing air through narrowed, inflamed airways while trying to overcome trapped air. An asthma patient is fighting severe bronchospasm. These patients aren't simply working faster, they're working dramatically harder with every breath. As the work of breathing increases, so does oxygen consumption by the respiratory muscles. The patient begins to tire. You'll often see nasal flaring, retractions, use of accessory muscles, tripod positioning, short one or two word sentences, diaphoresis, and increasing anxiety. If we don't intervene, respiratory muscle fatigue develops, ventilation becomes inadequate, carbon dioxide begins to rise, oxygenation worsens, and the patient progresses toward respiratory failure. Our goal as EMS providers is to recognize that increased work of breathing before the patient reaches that point. That's exactly where CPAP and BiPAP become valuable. Rather than waiting until the patient is exhausted, these therapies help unload the respiratory muscles, improve gas exchange, and buy the patient time while we treat the underlying cause. When evaluating a patient in respiratory distress, it helps to think about whether the lungs are difficult to expand or whether air is having difficulty moving through the airways. Those are two very different problems. On the left side of the slide, we have low compliance or stiff lungs. Compliance describes how easily the lungs and chest wall expand. Healthy lungs are flexible and inflate without requiring excessive effort. When compliance decreases, the lungs become harder to open. Think about acute pulmonary edema or ARDS. In these conditions, fluid and inflammation make the lungs heavy, stiff, and difficult to expand. The patient may still be generating a strong respiratory effort, but each breath requires much more work because the alveoli resist opening. At the alveolar level, some air may still reach the lungs, but fluid interferes with oxygen crossing into the bloodstream. That is why these patients can remain profoundly hypoxic even though they are breathing rapidly and forcefully. The primary problem is oxygenation. By applying continuous pressure that recruits alveoli, keeps them open between breaths, and improves the surface area available for gas exchange. In pulmonary edema, that pressure can also help move fluid out of the alveolar space and reduce the workload on the failing heart. Now compare that with the right side of the slide. Here, the problem is high airway resistance. Resistance describes how difficult it is to move air through the conducting airways. In COPD and asthma, the bronchioles become narrowed because of bronchospasm, inflammation, mucus, or loss of structural support. Air may enter during inspiration, but the narrowed or collapsing airways make exhalation much more difficult. Not completely empty the lungs before the next breath begins. Air becomes trapped, the lungs progressively hyperinflate, and carbon dioxide begins to accumulate. This patient may be moving air, but they are not moving it effectively. That a PAP ventilation problem. Because the higher inspiratory pressure helps increase tidal volume and reduces the effort required to inhale. The expiratory pressure helps prevent small airway and alveolar collapse. Together, those two pressure levels improve ventilation, assist carbon dioxide removal, and reduce respiratory muscle fatigue. This distinction is clinically important because both patients may look short of breath, anxious, apneic, and exhausted. However, the physiology driving their distress is different. The patient with low compliance needs help opening the lungs and improving gas exchange. The patient with high resistance needs help moving air in and out. As you assess your patient, do not stop at the diagnosis of respiratory distress. Ask yourself whether you are dealing primarily with stiff lungs or obstructed airways, because identifying that difference moves you much closer to choosing the correct form of non-invasive support. So we've identified two very different physiologic problems. One patient has stiff lungs that won't oxygenate well. The other has obstructed airways that can't move air effectively. The next step is recognizing that these aren't just different diseases. They're different respiratory failures. One is an oxygenation problem. The other is a ventilation problem. This is probably the single most important concept in the entire CPAP and BiPAP discussion. As EMS providers, we often say a patient is having trouble breathing, but that's actually a very broad statement. The real question should always be, what part of breathing is failing? Is the patient unable to get oxygen into the bloodstream, or are they unable to remove carbon dioxide from the body? Those are two completely different physiologic problems, and they require two different solutions. Let's start with oxygenation. Oxygenation simply means getting oxygen across the alveolar membrane and into the bloodstream. We measure it with pulse oximetry in the field and in the hospital by looking at the arterial oxygen level, PaO2. When oxygenation fails, the problem usually exists at the alveolar level. Think about pulmonary edema. The alveoli are flooded with fluid. Or pneumonia, where inflammatory fluid fills portions of the lung. Or ARDS, where widespread inflammation causes alveolar collapse. In every one of those situations, the patient may be moving air, but oxygen cannot effectively cross into the pulmonary capillaries. That's why they become hypoxic. The solution isn't necessarily giving more oxygen. It's improving the environment where gas exchange occurs. That's exactly what CPAP-PAP does. It recruits collapsed alveoli, increases functional residual capacity, improves perfusion matching, and creates more surface area for oxygen to enter the bloodstream. Now let's compare that to ventilation. Ventilation is completely different. Ventilation is the movement of air. More specifically, it's the removal of carbon dioxide. When ventilation fails, the issue isn't oxygen crossing into the blood. The issue is that carbon dioxide can't get out. Think about severe COPD. Airways become narrowed from bronchospasm and inflammation. Air gets trapped. Each breath becomes less effective than the one before. Carbon dioxide begins to accumulate because the patient simply cannot move enough fresh air. The same thing happens when respiratory muscles become exhausted, or when neuromuscular diseases weaken the muscles responsible for breathing. The lungs themselves may still be capable of exchanging oxygen. The patient just can't ventilate effectively enough to eliminate CO2. That's where BiPAP changes the physiology. The inspiratory pressure assists each breath, increasing tidal volume and improving motion. As ventilation improves, carbon dioxide begins leaving the body again, respiratory muscle fatigue decreases, and many patients avoid intubation altogether. This is why I want you to stop thinking in terms of diagnoses and start thinking in terms of physiology. Don't ask yourself, does this patient have CHF or COPD? Instead ask, is this primarily an oxygenation failure or a ventilation failure? Because once you answer that question correctly, choosing between CPAP and BiPAP often becomes remarkably straightforward. And if you remember nothing else from this slide, remember the statement highlighted at the bottom. CPAP improves the environment inside the lungs. BiPAP helps the patient breathe. That single distinction will guide countless airway decisions throughout your career. When we're caring for patients in the pre-hospital environment, it's helpful to think of respiratory failure as falling into one of two major categories. The first is type 1 respiratory failure, also called hypoxic respiratory failure. These patients have one primary problem. They cannot adequately oxygenate their blood. Notice what's happening in the example on the top half of the slide. This patient is in acute pulmonary edema. His oxygen saturation is critically low, he's breathing rapidly, and he's obviously working hard just to maintain oxygen delivery. Despite that effort, oxygen simply cannot cross the fluid-filled alveoli effectively. One thing you'll often notice is that these patients may initially have a normal or even low carbon dioxide level. That's because they're breathing so rapidly they're actually blowing off CO2. Their ventilation is still functioning reasonably well for now. Their problem isn't moving air. Their problem is gas exchange. This is exactly the patient CPAP was designed for. By recruiting alveoli, improving functional residual capacity, and pushing fluid away from the gas exchange surface, CPAP attacks the underlying physiology. Numerous studies have shown that early CPAP in acute pulmonary edema decreases the need for intubation, reduces ICU admissions, and improves patient outcomes. That's why many EMS systems consider it one of the effective interventions we perform. Now let's compare that to type 2 respiratory failure, or hypercapnic respiratory failure. These patients have a completely different problem. They're no longer ventilating adequately. Take a look at the patient in the lower half of the slide. This is a classic COPD exacerbation. His oxygen saturation, but look at the end tidal CO2. It's significantly elevated. His respiratory rate remains high, yet he's becoming fatigued because each breath is becoming less effective. Air is trapped behind narrowed airways. Minute ventilation is falling. Carbon dioxide continues to accumulate. If nothing changes, respiratory muscle fatigue progresses, mental status declines, and eventually respiratory arrest follows. This is where BiPAP becomes such a powerful intervention. Rather than simply supplying oxygen, BiPAP assists every breath. The increased inspiratory pressure improves tidal volume, enhances carbon dioxide elimination, and unloads exhausted respiratory muscles. In many patients, additional support is enough to reverse the downward spiral before invasive airway management becomes necessary. One point I'd like to emphasize is that these categories aren't just academic definitions. They're tools that help us think. Instead of immediately focusing on the diagnosis, ask yourself what kind of respiratory failure you're actually. Is this patient hypoxic because oxygen can't reach the bloodstream, or are they hypercapnic because they can't move enough air? When you answer that question correctly, the treatment pathway becomes much clearer. And remember, our goal isn't simply to improve the numbers on the monitor. Our goal is to recognize the physiology early enough that we can intervene before the patient reaches the point where intubation becomes unavoidable. That's exactly why understanding these two types of respiratory failure is so valuable in the field. It helps us choose the right therapy at the right time for the right patient. Now that we've identified which patients suffer from hypoxic respiratory failure and from hypercapnic respiratory failure, let's look at the first tool in our respiratory toolbox, CPAP. To use CPAP effectively, we need to understand exactly what it does, and just as importantly, what it doesn't do. CPAP stands for continuous positive airway pressure, and the key word in that name is continuous. Unlike BiPAP, CPAP delivers one constant level of pressure during both inspiration and expiration. If you've set CPAP to 10 centimeters of water pressure, the patient receives 10 centimeters throughout the entire respiratory cycle. There isn't a higher inspiratory pressure or a lower expiratory pressure, it's simply one constant pressure. One misconception I often hear is that CPAP is breathing for the patient. It isn't. The patient still generates every breath. They decide when to inhale, how often they breathe, and how much effort they put into each breath. CPAP simply changes movement inside the lungs by maintaining positive pressure throughout the airway. Think of it as holding the lungs open. Normally, every time we exhale, some alveoli begin to collapse. In disease states such as pulmonary edema, pneumonia, or ARDS, many alveoli may already be flooded or completely closed. Once those alveoli collapse, oxygen has a much harder time reaching the bloodstream. CPAP helps prevent that collapse. By maintaining positive pressure, it recruits additional alveoli into gas exchange, increases functional residual capacity, and creates a larger surface area for oxygen diffusion. That's why oxygen saturation often begins improving within just a few minutes after CPAP is applied. In acute cardiogenic pulmonary edema, CPAP provides another major benefit. Positive intrathoracic pressure decreases venous return to the heart, reducing preload. It also decreases left ventricular afterload, making it easier for the failing heart to eject blood. As pulmonary capillary pressures fall, fluid begins moving out of the alveoli and back into the vascular space. The patient isn't just receiving oxygen, we're actually changing the underlying physiology that's causing the respiratory distress. Another benefit you'll notice is a reduction in the work of breathing. When alveoli remain open, each breath becomes more efficient. The patient no longer has to generate tremendous negative pressure just to inflate stiff, fluid-filled lungs. Respiratory muscle fatigue decreases, respiratory rate often slows, and patients frequently become much more comfortable within minutes. So who is CPAP best suited for? Think about patients with oxygenation problems. Acute congestive heart failure and pulmonary edema are complications we encounter in EMS. CPAP is also extremely effective for hypoxic respiratory failure caused by pneumonia or other conditions where alveoli remain recruitable. Notice that all of these conditions share one thing in common. The patient can still move air reasonably well. Their problem isn't ventilation. Their problem is oxygen exchange. It's an important distinction because CPAP is not designed to remove carbon dioxide. If the patient's primary issue is ventilatory failure with rising CO2 levels, CPAP alone may not provide enough support. As pre-hospital clinicians, we should always ask ourselves one simple question before reaching for non-invasive ventilation. Does this patient need help getting oxygen into the bloodstream, or do they need help moving air? If the answer is oxygenation, CPAP is often the right tool. If the answer is ventilation, we'll need something different, and that's exactly what we'll discuss next when we move into BiPAP. We've defined what CPAP is and who it's designed to help. Now let's take a closer look at what's actually happening inside the lungs after we place the mask and begin applying positive pressure. This slide illustrates why CPAP is so effective, particularly for patients with acute pulmonary edema and other forms of hypoxic respiratory failure. Let's start with the image on the left, the lungs before CPAP is applied. Notice the alveoli are partially collapsed and filled with fluid. Instead of being thin, air-filled sacs where oxygen easily diffuses into the bloodstream, they're flooded and compressed. Oxygen has a much longer distance to travel before reaching the pulmonary capillaries, and in some alveoli, gas exchange isn't occurring at all. The patient responds by breathing harder and faster. Respiratory rate climbs. Accessory muscles become involved. The patient, they're suffocating despite moving large volumes of air. That's because the problem isn't the amount of air entering the mouth. It's that oxygen can't effectively cross into the blood. This is classic type 1 or hypoxic respiratory failure. Now look at what happens after CPAP is applied. By maintaining a constant positive pressure throughout the breathing cycle, CPAP increases the pressure inside the alveoli. Those partially collapsed air sacs begin reopening, a process we call alveolar recruitment. Instead of repeatedly collapsing with every exhalation, they remain open. Immediately, the amount of functioning lung available for gas exchange increases. As more alveoli participate in oxygen exchange, oxygen saturation begins improving, often within just a few minutes. At the same time, the positive pressure begins pushing fluid away from the alveolar membrane. It's important to remember that CPAP doesn't magically remove fluid from the lungs. Rather, by improving pressure relationships inside the chest and reducing preload and afterload, it begins shifting back into the pulmonary circulation where it belongs. The result is a thinner barrier between the alveolus and the bloodstream, allowing oxygen to diffuse much more efficiently. You'll also notice another important effect on the patient. Because the lungs are already partially inflated, the diaphragm doesn't have to generate as much negative pressure with every breath. The respiratory muscles become more efficient, work of breathing decreases, and patients often report that they can finally catch their breath. As EMS clinicians, you'll frequently witness this transformation. A patient who arrives sitting bolt upright, gasping for air, speaking only one or two words at a time, may begin speaking in full sentences after several minutes of effective CPAP therapy. Respiratory rate slows. Accessory muscle use decreases. Pulse oximetry improves. Anxiety begins to resolve because the sensation of air hunger is diminishing. This is why CPAP has become one of the most valuable interventions we have for acute pulmonary edema. When applied early, it improves oxygenation, decreases respiratory distress, reduces the need for endotracheal intubation, and has been shown to improve patient outcomes. The important lesson from this slide is that CPAP doesn't simply provide oxygen. It changes lung physiology. By recruiting alveoli, improving gas exchange, reducing pulmonary edema, and decreasing the work of breathing, CPAP treats the underlying problem rather than simply masking the symptoms. Understanding that physiology helps us recognize why CPAP works so well in some patients, and why it may not be enough for patients whose primary problem isn't oxygenation, but ventilation. Now that we've seen the mechanics of how CPAP's alveoli and improves oxygenation, let's apply that physiology to the patient we use CPAP on most often in EMS, the patient with acute congestive heart failure and pulmonary edema. Acute cardiogenic pulmonary edema is one of the true respiratory emergencies where EMS can make an immediate difference. Understanding the disease process helps explain why CPAP has become one of the most valuable interventions we can provide before the patient ever reaches the emergency department. Let's begin on the left side of the slide. Everything starts with a heart that is no longer pumping effectively, most commonly the left ventricle. When the left ventricle fails, blood begins backing up into the pulmonary circulation. As pressure inside the pulmonary capillaries rises, fluid is forced across the capillary membrane and into the lung tissue, and eventually into the alveoli themselves. Once fluid enters the alveoli, they are no longer filled with air. They're filled with fluid. Oxygen cannot efficiently cross that fluid barrier into the bloodstream, and gas exchange begins to fail. The patient's body immediately tries to compensate. Respiratory rate increases dramatically in an attempt to improve oxygen. The patient becomes tachypneic, anxious, diaphoretic, and often sits upright because lying flat makes the pulmonary congestion even worse. As the work of breathing increases, respiratory muscles begin consuming more oxygen themselves, further worsening the imbalance between oxygen supply and demand. If we do nothing, the cycle continues. More fluid accumulates, more alveoli become unavailable for gas exchange. Hypoxemia worsens. The patient tires. Eventually, they may progress to respiratory failure requiring endotracheal intubation. Now let's move across the slide and look at what happens when CPAP is introduced. The first thing CPAP does is increase intrathoracic pressure. While that might sound concerning initially, in this patient it's actually therapeutic. The increased pressure decreases venous return to the heart, reducing preload. At the same time, it decreases left ventricular afterload, making it easier for the failing heart to eject blood forward instead of allowing pressure to continue backing up into the lungs. As pulmonary capillary pressure begins to fall, fluid gradually shifts away from the alveoli and back into the pulmonary circulation. At the same time, CPAP recruits collapsed alveoli by holding them open throughout the entire respiratory cycle. Suddenly, many alveoli that weren't participating in gas exchange begin functioning again. The combined result is exactly what we want to achieve. Oxygen exchange improves. SpO2 begins to rise. The patient's respiratory effort decreases because every breath is becoming more effective. Within several minutes, many patients who initially appeared to be in extremis begin speaking in longer sentences. Accessory muscle use decreases, respiratory rate slows, and their anxiety starts to resolve. This improvement isn't simply because we've given oxygen. It's because we've interrupted the disease process. CPAP changes the physiology. As pre-hospital clinicians, we should remember that time matters. Every minute we delay CPAP allows pulmonary edema to worsen and respiratory fatigue to increase. Conversely, recognition and early application of CPAP can significantly reduce the need for intubation, shorten ICU stays, and improve survival. The take-home message from this slide is straightforward. Patients with acute pulmonary edema don't primarily need more oxygen. They need functioning alveoli. CPAP restores those alveoli, reduces cardiac, improves oxygenation, and interrupts the downward spiral before respiratory failure occurs. Now that we've seen why CPAP works so well in acute pulmonary edema, the next question becomes, when should we be reaching for CPAP in the field? Let's look at the patients who benefit the most from this intervention. One of the biggest decisions we make as EMS clinicians is determining whether a patient is appropriate for CPAP. The key to making that decision isn't memorizing a list of diagnoses, it's identifying the underlying physiology. Remember our guiding principle throughout this course. When the primary problem is oxygenation, CPAP is usually the right tool. Let's look at the common indications. The first, and by far the most important in pre-hospital medicine, is acute cardiogenic pulmonary edema. This is the patient sitting bolt upright, gasping for air, diaphoretic, hypertensive, and often unable to complete a sentence. They have diffuse crackles throughout the lungs and profound hypoxia because their alveoli are filling with fluid. For this patient, CPAP is truly the gold standard pre-hospital intervention. When applied early, it improves oxygenation, decreases preload and afterload, reduces respiratory distress, lowers the likelihood of intubation, and has consistently been shown to improve patient outcomes. In many EMS systems, this is one of the highest impact interventions we can provide before arriving at the hospital. The second indication is pneumonia with acute respiratory distress. Patients with severe pneumonia often have inflamed, partially fluid-filled alveoli that are no longer participating effectively in gas exchange. CPAP can recruit those alveoli and improve oxyfusion. However, it's important to recognize that pneumonia patients are not identical to pulmonary edema patients. They require close monitoring because some may have significant sepsis or hypotension, conditions that require careful clinical judgment before initiating positive pressure ventilation. Next is hypoxic respiratory failure. These are patients whose oxygen saturation remains low despite supplemental oxygen. Their lungs still have recruitable alveoli, but oxygen simply isn't crossing efficiently into the bloodstream. Examples include pulmonary edema, pneumonia, early ARDS, or other diseases causing impaired gas exchange. CPAP can often dramatically improve oxygenation by reopening collapsed alveoli and increasing functional residual capacity. Finally, although encountered less frequently, near drowning is another situation where CPAP can be beneficial. Following a drowning event, aspiration and disruption of surfactant cause alveolar collapse and impaired oxygen exchange. If the patient is awake, protecting the and cooperative, CPAP may improve oxygenation while reducing the work of breathing during transport. Notice what every indication on this slide has in common. The problem isn't primarily moving air. The patient is still ventilating. The problem is that oxygen cannot effectively reach the bloodstream. That's why CPAP works. It improves the environment within the lungs, allowing gas exchange to occur more efficiently. As pre-hospital providers, we also have to remember that timing matters. Waiting until the patient is profoundly exhausted often means we've missed the opportunity to achieve the greatest benefit. CPAP works best when applied before respiratory muscles fail, while the patient can have spontaneous breaths. So rather than asking, does this patient have CHF or does this patient have pneumonia? Ask yourself a more useful clinical question. Is this patient failing because they can't oxygenate? If the answer is yes, and they meet the appropriate criteria, CPAP should be one of the first interventions. That's the mindset we want to develop, not treating diagnoses, but treating physiology. We've identified the patients who benefit most from CPAP. Now let's tie everything together by reviewing exactly why CPAP produces such dramatic improvements in those patients and what changes we should expect to see after it's applied. At this point, we've discussed normal breathing, oxygenation versus ventilation, respiratory failure, and the indications for CPAP. This slide brings all of those concepts together. The first statement on the left is probably the most important takeaway of the entire CPAP section. The alveoli are still ventilating. They're just poorly oxygenating. Think about the patient with pulmonary edema or pneumonia. Air is still reaching many of the alveoli, but because they're collapsed, partially flooded, or unstable, oxygen can't efficiently move across the alveolar membrane into the bloodstream. The patient isn't failing because they can't breathe. They're failing because their lungs can't exchange evenly. That's where CPAP makes all the difference. Instead of forcing additional breaths, CPAP restores the environment needed for normal gas exchange. It increases pressure throughout the airways and alveoli, helping them remain open throughout both inspiration and expiration. Look at the comparison in the center of the slide. Without CPAP, alveoli collapse during exhalation. Lung volume decreases, fluid occupies valuable gas exchange space, and oxygen struggles to reach the bloodstream. As oxygen levels fall, the patient compensates by breathing faster and harder. Their respiratory muscles begin consuming more oxygen, anxiety increases, heart rate climbs, and the cycle of rest stress continues. Eventually, many patients become exhausted. Now compare that to the right side after CPAP has been applied. Positive pressure splints the airways open and stabilizes the alveoli. Lung volume increases, more alveoli participate in gas exchange, and oxygen can once again move efficiently into the pulmonary capillary. Notice another important effect. Because the lungs are already partially inflated, the diaphragm doesn't have to generate nearly as much negative pressure to produce the next breath. Every breath becomes easier and more effective. Clinically, this is exactly what we observe in the field. The respiratory rate begins slowing, accessory muscle use decreases, the patient's ability to speak improves, oxygen saturation starts climbing. Their anxiety often decreases because they're no longer experiencing the sensation of suffocating. One point worth mentioning is the effect on carbon dioxide. Although CPAP is not considered a ventilatory support device like BiPAP, improving lung recruitment often efficient ventilation. Some patients may demonstrate a modest decrease in ETO2 simply because they're moving air through healthier, reopened alveoli. However, that improvement is secondary. The primary purpose of CPAP remains improving oxygenation, not actively removing carbon dioxide. That's an important distinction because it helps us avoid choosing the wrong therapy for the wrong patient. As EMS providers, we should never think of CPAP as simply putting a mask on. We're performing a physiologic intervention. We're increasing functional residual capacity. We're recruiting collapsed alveoli. We're improving ventilation perfusion matching. We're decreasing the work of breathing, and we're often interrupting a downward spiral that would otherwise lead to respiratory fatigue, respiratory failure, and ultimately endotracheal intubation. The message I want you to remember from this slide is simple. CPAP doesn't breathe for the patient. It restores the lungs' ability to do what they're designed to do. When we understand biology, choosing the right patient for CPAP becomes much easier and our treatment becomes far more effective. We've spent the last several slides discussing what CPAP can accomplish and why it's such an effective therapy. But knowing what CPAP can't do is just as important. Understanding its limitations helps us recognize when CPAP is appropriate and when another intervention is needed. One of the most common mistakes made with CPAP is expecting it to solve every respiratory problem. It won't. CPAP is an outstanding tool, but like every intervention we use in EMS, it has limitations. Understanding those limitations is what separates simply applying a device from practicing sound clinical medicine. Let's start with the first limitation. CPAP does not provide ventilatory support. This is probably the single most important concept on this slide. CPAP does not deliver breaths. It does not increase tidal volume. It does not force air into the lungs. It simply provides a constant pressure that the patient breathes against. That means the patient must still perform the work of moving air. If the patient becomes fatigued and can no longer generate an adequate tidal volume, CPAP cannot compensate for that loss. That's why CPAP is not considered a ventilatory support device. The second limitation naturally follows the first. CPAP does not remove carbon dioxide. Remember our discussion on oxygenation versus ventilation. Carbon dioxide elimination depends on moving fresh air into the alveoli and removing stale air with each breath. Since CPAP doesn't increase tidal volume, it doesn't actively improve ventilation. Now, you may occasionally see a slight decrease in ETCO2 after starting CPAP because oxygenation improves, respiratory distress decreases, and ventilation perfusion matching becomes more efficient. But that's an indirect effect. If the patient's primary problem is rising CO2 because they're no longer moving enough air, CPAP alone is not the answer. Those patients often require BiPAP, which we'll discuss shortly, because BiPAP actually assists ventilation by augmenting each breath. It is one we assess before we even place the mask. The patient must have an adequate respiratory drive. CPAP works with the patient's own breathing efforts. The patient must be awake enough to protect their airway, capable of following commands, and able to initiate spontaneous respirations. Think about the patient who's becoming progressively somnolent from hypercapnia. Their respiratory rate is slowing, their tidal volumes are decreasing. They're beginning to lose consciousness. Putting CPAP on that patient won't solve the problem because the device isn't generating breaths. It still depends on the patient's own respiratory effort. That's why patient selection is so critical, as we're constantly reassessing. If a patient initially tolerates CPAP but then becomes increasingly fatigued, develops worsening mental status, or shows signs of ventilatory failure, we have to recognize that the disease process is progressing beyond what CPAP can treat. At that point, continuing the same therapy isn't helping the patient. It's delaying the next intervention. That's why I like the statement at the bottom of this slide. CPAP works with the patient, not for the patient. The patient is still doing the breathing. CPAP simply makes each breath more efficient by improving oxygenation. If the patient can no longer breathe effectively on their own, it's time to recognize that CPAP has reached its limit. Understanding those limits allows us to transition confidently to the next tool in our respiratory toolbox, because some patients don't just need oxygenation support, they need help ventilating. And that's exactly where BiPAP begins to separate itself from CPAP. Now that we've established where CPAP reaches its limits, next question becomes, what do we use when the patient doesn't just need oxygen, they need help breathing? That's where BiPAP enters the picture. Unlike CPAP's single continuous pressure, BiPAP actively assists ventilation while still improving oxygenation. Now let's introduce the second form of non-invasive positive pressure ventilation that we commonly use in EMS, BiPAP, or bilevel positive airway pressure. The word bilevel is really the key to understanding how this device works. Unlike CPAP, which provides one continuous pressure throughout the entire breathing cycle, BiPAP delivers two different pressure levels, one during inhalation and another during exhalation. Those two pressures are called IPAP and EPAP. Let's start with IPAP, or inspiratory positive airway pressure. This is the higher pressure that's delivered as the patient inhales. Its primary job is to assist the patient's inspiratory effort. Think of IPAP as a gentle push with every breath. That additional pressure increases tidal volume, improves alveolar ventilation, reduces the work of breathing, and helps eliminate carbon dioxide more effectively. Patients who are tiring from COPD, severe asthma, obesity, hypoventilation, or neuromuscular weakness often experience immediate relief because they no longer have to generate every bit of inspiratory force on their own. Now let's look at EPAP, or expiratory positive airway pressure. EPAP is the lower pressure maintained during exhalation. If this sounds familiar, it should. EPAP functions very much like CPAP. It splints open the upper airway, prevents alveolar collapse, recruits additional alveoli for gas exchange, and improves oxygenation. So, when we combine these two pressures, something important happens. IPAP improves ventilation. EPAP improves oxygenation. Together, they allow us to treat patients who have problems with both oxygen delivery and carbon dioxide removal. That's why BiPAP is such a powerful therapy for respiratory failure. Take the patient with both COPD and pneumonia. They're struggling to oxygenate because inflammatory changes have impaired gas exchange. At the same time, they're retaining carbon dioxide because obstructed airways and respiratory muscle fatigue prevent effective ventilation. CPAP would certainly help improve oxygenation, but it wouldn't assist ventilation. BiPAP addresses both physiologic problems simultaneously. The panel on the right summarizes several situations where BiPAP may be appropriate in the pre-hospital environment. The most common indication is COPD exacerbation with hypercapnic respiratory failure. These patients often have elevated readings, prolonged expiration, accessory muscle use, and increasing fatigue. BiPAP can dramatically reduce their work of breathing while improving ventilation. BiPAP may also be useful in selected patients with acute cardiogenic pulmonary edema, particularly when they are beginning to retain carbon dioxide or show signs of ventilatory fatigue. Patients with obesity, hypoventilation syndrome, post-extubation respiratory support, neuromuscular weakness, and severe asthma may also benefit when protocols and medical direction support its use. The caution box at the bottom deserves just as much attention. BiPAP is a powerful therapy, but it should never delay definitive airway management. If the patient's mental status is deteriorating, they can no longer protect their airway, or they continue to worsen despite non-invasive ventilation. It's time to move toward advanced airway management. Finally, notice the example starting settings listed on the slide. While individual protocols vary, the principle remains the same. Start with conservative pressures, reassess continuously, and titrate based on the patient's response rather than simply chasing numbers. Ultimately, BiPAP gives us something CPAP cannot. It doesn't just improve the environment inside the lungs, it actually assists the patient's breathing. That additional inspiratory support is often the difference between a patient who continues to fatigue and one who stabilizes long enough to avoid intubation. Now that we understand what BiPAP is and the purpose of IPAP and EPAP, let's take a closer look at what actually happens inside the body when those two pressures are applied. Understanding the physiology explains why BiPAP can often stabilize patients who would otherwise continue to deteriorate. This slide brings everything together by showing how BiPAP changes respiratory physiology from the moment the patient begins breathing through the mask. Remember that BiPAP isn't simply delivering oxygen, it's changing the mechanics of breathing itself. The most important concept to understand is that the two pressure levels perform two different jobs simultaneously. Let's begin with IPAP, the inspiratory pressure. During every inspiration, the ventilator increases airway pressure above the expiratory baseline. That higher pressure assists the patient's own effort to inhale. Because the machine is doing part of the work, the patient no longer has to generate as much negative intrathoracic pressure with every breath. As a result, tidal volume increases. More fresh air reaches the alveoli, minute ventilation improves, and because ventilation improves, carbon dioxide is removed more effectively. This is why one of the hallmark improvements after initiating BiPAP is a gradual decrease in EtCO2 in patients suffering from hypercapnic respiratory failure. Patients often describe this as finally being able to get a deep breath. Now let's look at EPAP, the expiratory pressure. While the inspiratory pressure cycles up and down, the expiratory pressure never falls to zero. Instead, EPAP maintains a continuous baseline pressure that keeps the alveoli open at the end of exhalation. As alveolar collapse increases functional residual capacity, recruits additional alveoli for gas exchange, and improves oxygenation. So while IPAP is primarily improving ventilation, EPAP continues to perform many of the same functions that we discussed with CPAP. Together, these pressures allow BiPAP to improve both oxygen delivery and carbon dioxide elimination simultaneously. The lower portion of the slide illustrates how those physiologic improvements translate into clinical improvement. First, ventilation improves because tidal volume and minute ventilation increase. Second, oxygenation improves as additional alveoli become available for gas exchange. Third, because the ventilator is assisting every breath, respiratory muscles don't have to work nearly as hard. Think about a patient with a severe COPD exacerbation. For hours, they've been using every accessory muscle they have just to move a small amount of air. Their diaphragm is becoming fatigued. Their chest wall is exhausted. BiPAP essentially shares the workload. Instead of fighting every breath alone, the patient now receives assistance with every inspiration. That reduction in work of breathing is often one of the first clinical improvements you'll observe. Respiratory rate begins to decrease. Accessory muscle use becomes less pronounced. Patients often appear calmer because they're know their own physiology. The next physiologic benefit is one we sometimes overlook: improved cardiac function. As oxygenation improves and respiratory distress decreases, myocardial oxygen demand falls. The heart no longer has to compensate for profound hypoxia and severe respiratory effort. In many patients, heart rate begins to normalize, blood pressure stabilizes, and overall tissue perfusion improves. All of these physiologic improvements contribute to the final outcome shown on the slide. Patients become more comfortable. Gas exchange improves. The likelihood of respiratory failure decreases. Many patients avoid endotracheal intubation altogether. Hospital may be reduced, and patient outcomes improve. The key takeaway is simple. BiPAP isn't just another oxygen delivery device. It is a therapy that changes respiratory mechanics. By combining inspiratory pressure that assists ventilation with expiratory pressure that maintains alveolar recruitment, BiPAP simultaneously reduces carbon dioxide, improves oxygenation, decreases respiratory muscle fatigue, and gives critically ill patients an opportunity to recover without requiring invasive mechanical ventilation. Now that we've seen how BiPAP changes respiratory physiology, let's apply those principles to one of the most common patients we encounter in EMS. To understand why BiPAP is so effective in COPD exacerbations, we first need to understand exactly what's happening inside the lungs during the disease process. COPD is fundamentally a disease of ventilation. Unlike pulmonary edema, where oxygen struggles to cross fluid-filled alveoli, COPD patients usually have functioning alveoli. Their problem is getting air in and, more importantly, getting air back out. The disease develops over years of chronic inflammation, most commonly from cigarette smoking. That ongoing inflammation causes structural changes throughout the airways. The bronchi become chronically inflamed and narrowed. The walls of the airways thicken. Excess mucus is produced. At the same time, many patients develop emphysema, where the walls between alveoli are destroyed and the lungs lose their natural elasticity. That loss of recoil is one of the defining characteristics of COPD. Normally, when we exhale, the lungs naturally recoil like a stretched rubber band, helping push air out of the lungs. In COPD, that recoil is diminished. During exhalation, the small airways begin collapsing prematurely. Air becomes trapped inside the lungs because the patient simply can't empty them completely before taking the next breath. That process is known as air trapping, and over time, it leads to hyperinflation. Notice the arrows on the lungs in the illustration. With every breath, a little more air remains trapped. The lungs become increasingly overinflated, leaving less room for the next inhalation. As hyperinflation, the diaphragm becomes flattened. A flattened diaphragm loses much of its mechanical advantage. Now, every breath requires considerably more muscular effort. Patients begin recruiting accessory muscles in the neck, shoulders, and chest just to move air. As respiratory muscles fatigue, ventilation begins to decline. When ventilation decreases, carbon can no longer be adequately removed. EtCO2 and PaCO2 begin to rise. Initially, the body compensates, but eventually carbon dioxide retention leads to respiratory acidosis. This is why many COPD patients become progressively drowsy or confused. It's not simply because they're tired. It's because rising carbon dioxide is directly affecting cerebral function. The flow chart on the right side of the slide illustrates this progression beautifully. Chronic inflammation leads to airflow limitation. Airflow limitation produces air trapping and hyperinflation. Hyperinflation causes carbon dioxide retention and worsening hypoxemia. The increased work of breathing respiratory muscles. As those muscles tire, ventilation declines even further, creating a vicious cycle that continues until something interrupts it. Clinically, this is exactly what we see in the back of the ambulance. Patients have prolonged expiratory phases. They're wheezing. They're sitting upright because lying flat makes breathing impossible. Their respiratory rates are elevated, yet despite breathing quickly, they're moving very little effective air. You'll often see pursed lip breathing as they try to create their own positive airway pressure to keep those collapsing airways open during exhalation. That observation is important because it tells us something about treatment. These patients are already attempting to use positive pressure naturally. BiPAP simply provides that pressure more effectively while also assisting each breath. The key point from this slide is that COPD is not simply a problem of low oxygen. It's a disease of airflow obstruction, air trapping, respiratory muscle fatigue, and carbon dioxide retention. If we only focus on giving oxygen, we've treated only part of the problem. To truly improve these patients, we must reduce the work of breathing, improve ventilation, and help remove carbon dioxide. That's exactly where BiPAP becomes one of the most effective interventions we can provide in the pre-hospital environment. Now that we understand why COPD patients develop air trapping, carbon dioxide retention, and respiratory muscle fatigue, the next question becomes, which of those patients should receive BiPAP? Let's look at the clinical situations where BiPAP provides the greatest benefit in the pre-hospital setting. Choosing the correct patient is every bit as important as choosing the correct device. BiPAP is an incredibly effective intervention, but like any therapy, it works best when it's applied to the right physiology. The first and most common indication is an acute COPD exacerbation, and this is the patient that most of us immediately think about when BiPAP is mentioned. These patients typically present with severe dyspnea, prolonged expiratory phases, diffuse wheezing, accessory muscle use, and increasing fatigue. Their respiratory rate may be elevated, but despite breathing rapidly, they're moving very little effective air. If you have capnography available, you'll often see elevated ET2 values like the patient shown here with an EtCO2 of 58 millimeters of mercury. That elevated carbon dioxide tells you that ventilation is failing. BiPAP helps by unloading the respiratory muscles, increasing tidal volume, and improving carbon dioxide elimination before the patient reaches complete respiratory exhaustion. The patient is mixed COPD and congestive heart failure. These patients are particularly challenging because they have two different physiologic problems occurring simultaneously. They have airflow obstruction from COPD, making ventilation difficult. At the same time, pulmonary edema impairs oxygenation by filling the alveoli with fluid. CPAP alone would improve oxygenation, but it doesn't provide ventilatory support. BiPAP addresses both problems by improving oxygenation with EPAP while simultaneously assisting ventilation through IPAP. Mixed respiratory failure is one of the situations where BiPAP often provides a significant clinical advantage. The third indication is hypercapnic respiratory failure, regardless of the underlying diagnosis. While COPD is the classic cause, elevated carbon dioxide levels can also occur in patients with obesity, hypoventilation syndrome, chest wall disorders, neuromuscular disease, or other conditions that reduce effective ventilation. Whenever carbon dioxide is rising because the patient can't move enough air, BiPAP should be considered if they still have an intact respiratory drive. Next, notice the indication of respiratory fatigue. This is one of the most important clinical findings we can recognize in EMS. Patients don't usually fail because their lungs suddenly stop working. They fail because they become exhausted. Initially, breathe faster to compensate. Then they'll recruit accessory muscles. Eventually, they begin speaking fewer words. Their chest movement becomes smaller, and their respiratory rate may actually start to slow as fatigue worsens. Waiting until they're apneic means we've waited too long. The patient is still awake. They're maintaining their own airway. In the mask, their respiratory rate is improving. Although their EtCO2 remains elevated, they're now receiving assistance with every breath instead of struggling alone. That's exactly the window we're trying to identify. The goal is not to rescue a patient who's already in respiratory arrest. The goal is to recognize respiratory failure early enough that non-invasive ventilation can reverse the downward spiral before invasive airway management becomes necessary. The key takeaway from this slide is simple. BiPAP is indicated when ventilation is failing, the patient still has an adequate respiratory drive, and we have an opportunity to intervene before respiratory muscle fatigue progresses to complete failure. We've identified the patients who benefit most from BiPAP, but understanding why those patients improve is just as important. Let's look at how BiPAP changes the work of breathing and why that physiologic support can often prevent respiratory failure from progressing. This slide really captures the biggest advantage that BiPAP has over CPAP. CPAP opens the lungs and improves oxygenation. BiPAP does that too, but it also helps the patient breathe. That distinction is what makes BiPAP such a powerful therapy for patients with ventilatory failure. Take a look at the patient in the center of the slide. This is a patient with severe COPD who is working incredibly hard just to survive. Every breath requires tremendous effort. The diaphragm is fatigued. Accessory muscles are fully engaged. Carbon dioxide continues to rise because the patient simply can't move enough air. Without intervention, this patient is headed toward respiratory arrest. Now let's follow what BiPAP. The blue arrow represents IPAP, the inspiratory positive airway pressure. Every time the patient begins to inhale, the ventilator senses that effort and delivers additional inspiratory pressure. That pressure increases tidal volume, meaning each breath brings more fresh air into the lungs. Because tidal volume increases, minute ventilation also improves. More importantly, more carbon dioxide is removed with every breath. Notice the EtCO2 values on the monitor. Before BiPAP, the patient's EtCO2 was 68 millimeters of mercury. Now it's fallen to 52. That's not because BiPAP magically removes carbon dioxide. It's because the patient is finally ventilating again. At the same time, notice the green arrow representing EPAP. EPAP maintains positive pressure during exhalation, preventing alveolar collapse and keeping more lung units available for gas exchange. So while IPAP improves ventilation, EPAP continues to improve oxygenation. Together, they address both sides of respiration simultaneously. Now compare the physiologic changes shown on the monitors. The oxygen saturation has improved from 86% to 94%. Respiratory rate has decreased from 32 breaths per minute to 20. Heart rate has fallen from 118 to 96. Those aren't just numbers. They're signs that the patient's physiology is recovering. When patients no longer have to struggle for every breath, sympathetic stimulation decreases. Their heart doesn't have to work as hard. Their oxygen demand falls. Anxiety improves because they can finally move air effectively. One statement on this slide deserves special attention. BiPAP acts like a non-invasive vent, exactly how we should think about it. Unlike CPAP, which simply maintains one constant pressure, BiPAP actively assists each inspiration. It reduces the amount of work required from the respiratory muscles. Imagine trying to carry a heavy object up a flight of stairs by yourself. Now imagine someone taking half the weight off your shoulders. Your work, but you're no longer doing it alone. That's exactly what BiPAP does for the respiratory muscles. It doesn't replace spontaneous breathing. It assists it. That distinction is important because it explains why BiPAP works only in patients who still have an intact respiratory drive. The patient must initiate each breath. The machine simply amplifies that effort. As respiratory muscles recover, patients often begin speaking in full sentences again. Accessory muscle use decreases. Chest excursion becomes more effective. They look less anxious because they're no longer experiencing severe air hunger. Many patients will even tell you exactly what this patient says on the slide. I breathe better. That's often the first indication that your therapy is working. The final message at the bottom of this slide summarizes the entire concept perfectly. BiPAP doesn't just improve oxygenation, it unloads the work of breathing. For patients with ventilatory failure, that's the physiologic support they desperately need, and it's often the intervention that prevents progression to endotracheal intubation. By now, we've seen why BiPAP is such a powerful therapy, but every intervention we perform has potential risks. Understanding those complications and recognizing them early is just as important as knowing when to start BiPAP. BiPAP is an extremely safe and effective therapy when it's applied to the right patient and monitored appropriately. However, like every treatment we provide in EMS, it isn't completely without risk. Fortunately, most complications are predictable, preventable, and easily recognized through good patient assessment. Let's begin with gastric insufflation. Positive pressure doesn't always travel exclusively into the lungs. If airway pressures become excessive, or if the patient swallows air while trying to synchronize with the machine, some of that air can enter the stomach instead. As the stomach fills, patients may complain of abdominal fullness, bloating, nausea, or increasing discomfort. Besides being uncomfortable, gastric distension creates a more significant concern. A distended stomach increases the risk of vomiting. If a patient vomits while wearing a tightly sealed BiPAP mask and cannot remove it quickly, aspiration becomes a real danger. This is one of the reasons continuous observation is absolutely essential. Never place a patient on BiPAP and assume the machine will do the work for you. The second consideration is hypotension. Although we tend to associate hypotension more commonly with CPAP because of the continuous intrathoracic pressure, BiPAP can produce the same physiologic effect. Positive pressure increases pressure inside the chest. As intrathoracic pressure rises, venous return to the heart decreases. Less blood returning to the heart means lower preload. If preload falls significantly, cardiac output may decrease, leading to hypotension. Fortunately, this complication is relatively uncommon when appropriate pressures are used, but it becomes more likely in patients who are volume depleted, septic, or already hypotensive before therapy begins. This is why blood pressure should never be treated as a one-time measurement. It needs to be reassessed frequently throughout transport. Next, notice the third point on the slide. BiPAP requires monitoring and patient cooperation. This cannot be overstated. BiPAP only works if the patient tolerates the mask. Patients who become claustrophobic, anxious, or agitated may fight against the therapy rather than benefit from it. Taking an extra minute before applying the mask to explain what the patient should expect often makes a tremendous difference. I like to tell patients, this mask is going to feel unusual at first because it's pushing air toward you. Don't fight it. Let the machine help you breathe, and within a few breaths, it will begin to feel much easier. That brief explanation often transforms a patient from resisting the therapy to actively working with it. You'll also notice several reminders across the bottom of the slide. First, monitor vital signs and trends. Don't simply record numbers. Change over time. Is respiratory rate falling? Is ETCO2 improving? Is oxygen saturation increasing? Is heart rate decreasing? Those trends tell you whether your intervention is working. Second, watch for abdominal distension or nausea, which may signal gastric insufflation. Third, continuously assess mental status. An improving patient becomes calmer, more interactive, and more comfortable. A deteriorating patient becomes increasingly fatigued, confused, or difficult to arouse. Mental status is often one of the earliest indicators that non-invasive ventilation is either succeeding or failing. Finally, always ensure a good mask seal. A leaking mask not only reduces the effectiveness of therapy, but it also makes the machine work harder and often causes patient frustration. Sometimes simply repositioning the mask or adjusting the straps dramatically improves patient comfort and ventilation. The most important message on this slide is printed across the bottom. Continuous assessment is essential. BiPAP is not a forget it intervention. Successful non-invasive ventilation requires ongoing reassessment, frequent communication with the patient, careful monitoring of physiologic trends, and the willingness to recognize when it's working, and just as importantly, when it isn't. The best providers don't simply apply BiPAP. They continuously evaluate the patient's response and adjust their treatment plan accordingly. Now that we've discussed the strengths and limitations of both therapies individually, let's put them side by side. This comparison brings together everything we've learned and gives us a practical framework for choosing the right therapy for the right patient. This slide summarizes one of the most important concepts in the entire presentation. As EMS clinicians, we often ask ourselves a simple question: should I use CPAP or should I use BiPAP? The answer isn't based on which machine is newer or more advanced. It's based entirely on understanding what physiologic problem you're trying to fix. Let's walk through this comparison from top to bottom. First, look at the primary problem each therapy is designed to treat. CPAP is primarily an oxygenation therapy. Its goal is to improve oxygen transfer across the alveoli by keeping those alveoli open throughout the respiratory cycle. BiPAP, on the other hand, addresses both ventilation and oxygenation. It still improves oxygenation through EPAP, but it also actively assists ventilation through IFPAP, helping the patient move a larger tidal volume and eliminate carbon dioxide more effectively. The next row compares the pressure each therapy delivers. CPAP provides one continuous pressure throughout inspiration and expiration. That is excellent for recruiting alveoli and improving gas exchange. BiPAP provides two separate pressures. A higher inspiratory pressure, or IPAP, assists inhalation. A lower expiratory pressure, or EPAP, maintains alveolar recruitment during exhalation. Together, those two pressures support both breathing and gas exchange. Next, let's discuss oxygenation. Both therapies improve oxygenation because both keep alveoli open. This is why patients with pulmonary edema, pneumonia, or hypoxic respiratory failure often improve rapidly with either modality. Where the therapies begin to differ is with carbon dioxide removal. CPAP does not effectively remove CO2. Remember, CPAP doesn't generate tidal volume. The patient still has to do all of the ventilatory work themselves. BiPAP is different. Because IPAP augments each breath, tidal volume increases. Minute ventilation improves. Carbon dioxide elimination becomes much more effective. That's why BiPAP is so valuable in patients with COPD exacerbations and hypercapnic respiratory failure. Now look at the work of breathing row. CPAP reduces work of breathing moderately. By recruiting alveoli and improving oxygenation, patients don't have to work as hard to overcome stiff lungs. However, the patient is still generating every breath independently. BiPAP provides a much greater reduction in work of breathing. Every inch is assisted. Respiratory muscles become unloaded. Patients who were tiring just minutes before often begin breathing more comfortably because the machine is sharing the workload. Finally, look at the bottom row showing the best use for each therapy. CPAP excels in conditions where oxygenation is the primary problem. Examples include cardiogenic pulmonary edema, isolated hypoxia, pneumonia with preserved ventilation, and other conditions where the lungs need recruitment rather than ventilatory assistance. BiPAP is the preferred therapy when ventilation has become the limiting factor. Patients with COPD exacerbations, elevated EtCO2, respiratory muscle fatigue, or hypercapnic respiratory failure benefit from the additional inspiratory support that BiPAP provides. One important point I want to emphasize is that these therapies are not competitors. Neither one is universally better. They're simply different tools designed for different physiologic problems. The most successful EMS clinicians don't ask, "What should I use?" Instead, they ask, "Why is this patient failing?" If the patient is failing because they can't oxygenate, CPAP is usually the correct answer. If they're failing because they can't ventilate, BiPAP is usually the better choice. And if they have elements of both, BiPAP often provides the most comprehensive support. That's the mindset I hope you take away from this course. Don't treat the diagnosis. Treat the physiology. When you understand the physiology, the right treatment often becomes obvious. We've compared the strengths of CPAP and BiPAP, but in the back of your mind, you're probably thinking, "That's great, but how do I make the right decision on a real patient at 2 o'clock in the morning?" This next slide gives you a simple framework that you can apply to every respiratory call. If you remember nothing else from today's presentation, remember this slide. One simple question should guide your decision every time you consider non-invasive ventilation. Is the patient's primary problem oxygenation, ventilation, or both? That question is far more valuable than asking what diagnosis the patient has. Too often, clinicians decide based solely on hearing the word CHF or COPD. But medicine isn't always that straightforward. Patients don't always read the textbook before they call 911. Instead, assess the physiology in front of you. Start on the left side of the algorithm. If the patient is primarily suffering from an oxygenation problem, you'll usually see a low SO2 despite supplemental oxygen. If capnography is available, the EtCO2 is often normal or even low because the patient is still moving air. They're simply unable to transfer enough oxygen across diseased or fluid-filled alveoli. Think about conditions like acute cardiogenic pulmonary edema, pneumonia, atelectasis, or other causes of hypoxemic respiratory failure. These patients don't necessarily need help taking a bigger breath. They need help opening collapsed alveoli. That's where CPAP shines. By providing continuous positive pressure, CPAP recruits alveoli, improves functional residual capacity, and creates more surface area for oxygen to enter the bloodstream. Now look at the right side of the algorithm. If the patient is primarily suffering from a ventilation problem, the clues are different. Their ETO2 is elevated because they are no longer removing carbon dioxide effectively. Their respiratory rate may be high, but despite breathing faster, ventilation remains inadequate. You'll often notice accessory muscle use, prolonged expiratory phases, fatigue, and signs that the patient is working incredibly hard just to maintain ventilation. These are the classic findings seen in COPD exacerbations, severe asthma, hypercapnic respiratory failure, and certain neuromuscular disorders. These patients don't just need open lungs, they need assistance moving air. That's where BiPAP becomes the preferred therapy. The inspiratory pressure assists each breath, increasing tidal volume and improving CO2 elimination while simultaneously reducing respiratory muscle fatigue. Finally, recognize that not every patient fits neatly into one category. Some patients have mixed respiratory failure, a patient with COPD who develops pneumonia, a COPD patient who also has heart failure, a patient with severe respiratory distress who is both hypoxic and hypercapnic. These are some of the sickest respiratory patients we encounter. In these cases, BiPAP is often preferred because it addresses both components simultaneously. EPAP continues to lie and improve oxygenation. BiPAP supports ventilation and removes carbon dioxide. It provides the broadest physiologic support when both systems are failing. One point I want to emphasize is that this framework should never replace your ongoing assessment. It's simply your starting point. After initiating therapy, reassess continuously. Is the respiratory rate improving? Is oxygen saturation increasing? Is EtCO2 moving in the right direction? Is the patient's mental status improving? Is the work of breathing decreasing? If the answer is yes, you're probably treating the correct physiologic problem. If not, reassess your diagnosis, verify your equipment, and consider intervention or even endotracheal intubation is becoming necessary. The beauty of this decision framework is its simplicity. Instead of memorizing dozens of disease-specific rules, ask yourself one question. What is failing? If oxygenation is failing, think CPAP. If ventilation is failing, think BiPAP. If both are failing, BiPAP is the better starting point. When you focus on physiology instead of labels, your treatment decisions become faster, more logical, and ultimately more effective for the patient in front of you. A decision framework is helpful, but our patients don't arrive with a label that says oxygenation failure or ventilation failure. They arrive with signs and symptoms. The next step is learning how to recognize those clinical clues quickly so you can match what you see with the correct therapy. So, this slide takes everything we've discussed so far and brings it into the real world. When you're standing in a patient's living room or treating someone in the back of an ambulance, you don't have the luxury of a complete hospital workup. Your decision is based on what you can see, hear, and measure in the first few minutes. That's why recognizing clinical clues is so important. Let's start with the top example. This patient has crackles, severe hypertension, pink frothy sputum, and sudden respiratory distress. Those findings should immediately make you think about acute cardiogenic pulmonary edema. Notice that the monitor shows profound hypoxia, but there isn't evidence that carbon dioxide retention is an issue. This patient is drowning in their own pulmonary edema. Their alveoli are flooded with fluid. The problem isn't that they can't breathe. The problem is that oxygen can't cross into the bloodstream. That's why CPAP is usually the treatment of choice. CPAP recruits collapsed alveoli, improves oxygenation, decreases preload and afterload, and often produces dramatic improvement within minutes. Now let's move to the middle patient. Here the clues are very different. Instead of crackles, we hear wheezing. Instead of fluid-filled lungs, we have prolonged expiration and evidence of air trapping. The monitor tells us something equally important. The EtCO2 is elevated. This patient isn't just hypoxic. They're retaining carbon dioxide because they cannot move air effectively. This is classic COPD physiology. In this situation, simply opening alveoli isn't enough. The patient needs assistance with ventilation. That's why BiPAP is the better choice. The inspiratory pressure augments each breath, increases tidal volume, carbon dioxide elimination, and significantly decreases the work required to breathe. Finally, let's look at the bottom patient. This patient is perhaps the most concerning. Notice the shallow respirations, fatigue, declining level of consciousness, and an ETO2 that continues to rise. These are late signs. The patient is no longer compensating. The respiratory muscles are failing. If we don't intervene quickly, respiratory arrest may not be far behind. Again, this is where BiPAP can make a tremendous difference. By taking over part of the work of breathing, BiPAP allows exhausted respiratory muscles to recover while improving ventilation and reducing carbon dioxide levels. Important lesson from this slide is that no single finding should determine your treatment. Don't rely on wheezing alone. Don't rely on crackles alone. Don't rely on one monitor value. Instead, combine everything you know. Look at the patient's appearance. Listen to lung sounds. Evaluate the respiratory rate and effort. Assess mental status. Measure oxygen saturation. Use waveform capnography whenever available. Watch how the patient responds over the next several minutes. All of these pieces create the clinical picture. As experienced EMS clinicians, pattern recognition becomes one of our greatest strengths. The more patients you evaluate, the more quickly you'll recognize these presentations. Eventually, you'll walk into a room and immediately begin forming a physiologic diagnosis before you've even placed the monitor. That's exactly what we're trying to develop. Remember, we're not asking, does this patient have COPD? We're asking, is this patient failing to oxygenate, failing to ventilate, or beginning to fail at both? When you answer the question correctly, choosing CPAP or BiPAP becomes much more straightforward, and your patient receives the therapy that addresses the underlying physiology rather than simply treating the symptoms. Recognizing the patient's clinical presentation helps us choose the right therapy. But once we've made that decision, there are still several practical factors that determine whether non-invasive ventilation will be successful in the pre-hospital environment. Choosing CPAP or BiPAP correctly is only part of the equation. The other part is applying that therapy effectively in the unique environment we work in every day. Unlike the emergency department or intensive care unit, we have limited personnel, limited equipment, limited space, and a patient who may be bouncing down the road in the back of an ambulance. Success depends just as much on good clinical judgment as it does on understanding respiratory physiology. The first consideration is transport time. Whether your transport is 5 minutes or 45 minutes, your goal remains the same. Begin stabilizing the patient as early as possible. Don't wait until you're halfway to the hospital, PAP or BiPAP, if the patient clearly needs it. Every minute a patient spends struggling to breathe increases oxygen consumption, respiratory muscle fatigue, and physiologic stress. Early intervention often prevents deterioration before it occurs. At the same time, don't delay transport trying to achieve the perfect settings. Can and should be adjusted during transport. The priority is initiating appropriate therapy while continuing toward definitive care. The second consideration is equipment capability. No matter how advanced your CPAP or BiPAP device may be, it only works if it's functioning correctly. Before placing the mask, verify that you have an adequate oxygen supply, functioning tubing, a properly fitting mask, sufficient battery life if applicable, and monitoring equipment already in place. Know your device. Different manufacturers use different interfaces, alarms, menus, and adjustment methods. The time to learn your equipment is during training, not during a respiratory emergency. With your equipment translates directly into faster patient care and fewer interruptions during transport. The third consideration is provider familiarity. One of the greatest advantages in EMS is becoming exceptionally proficient with the equipment you use every day. If you understand how your device functions, how to troubleshoot leaks, how to titrate pressures, and how to coach anxious patients through the first few minutes of therapy, your success rate increases dramatically. Patient comfort also improves. Remember that many patients are frightened when the mask is first applied. Some will describe it as feeling like they're sticking their head out of a moving car window. Your coaching becomes just as important as the machine itself. Explain what they're going to feel. Encourage slow, steady breaths. Maintain eye contact. Offer reassurance. Many patients who initially want to pull the mask away become much more comfortable after the first minute or two with calm coaching from the provider. Throughout transport, continuous reassurance remains essential. Watch the patient's respiratory rate. Monitor oxygen saturation. Trend EtCO2 whenever available. Evaluate heart rate and blood pressure. Listen to lung sounds. Observe mental status. Ask a simple question every few minutes. Is this patient breathing easier than they were 5 minutes ago? If the answer is yes, supporting them while reassessing frequently. If they're worsening despite appropriate settings and a good mask seal, don't simply increase pressures without thinking. Reassess your diagnosis. Look for equipment issues. Consider complications such as hypotension, worsening fatigue, or inability to tolerate the mask. And most importantly, recognize when non-invasive ventilation is no longer enough. There are patients who will ultimately require advanced airway management despite our best efforts. The goal is not to avoid intubation at all costs. The goal is to identify the patients who can benefit from non-invasive ventilation while recognizing early when it's failing. In the pre-hospital environment, good outcomes come from combining strong clinical assessment, familiarity with your equipment, effective patient communication, and constant reassessment. When those elements come together, CPAP and BiPAP become powerful tools that can dramatically improve patient comfort, reduce respiratory failure, and often change the course of the patient's entire hospitalization before they ever reach the emergency department. Even with the right patient, the right equipment, and the right clinical decision, there are times when non-invasive ventilation simply isn't appropriate. Before applying any mask, we must always ask one final question. Is this patient actually a candidate for CPAP or BiPAP? This may be one of the most important safety slides in the entire presentation. CPAP and PAP are incredibly effective therapies, but only when they're applied to the right patient. Used in the wrong situation, they can delay definitive airway management and potentially make a critically ill patient worse. Let's go through the major contraindications. The first is altered mental status. Patients receiving CPAP or BiPAP must be awake enough to understand what's happening and cooperate with the therapy. They need to tolerate the mask, follow simple commands, and communicate if something is wrong. A patient who is becoming progressively lethargic, confused, or unresponsive may not protect their airway. That's a dangerous situation. Remember, these devices provide positive pressure. They do not protect the airway. If the patient's mental status is deteriorating despite treatment, it may be time to move toward definitive airway management. The second contraindication is an inability to protect the airway. Question: can this patient swallow their own secretions? Can they cough effectively? If they vomit, can they remove the mask? If the answer is no, CPAP and BiPAP become much higher risk. The concern isn't simply ineffective therapy. It's aspiration. A patient who aspirates while receiving positive pressure ventilation can rapidly deteriorate into complete respiratory failure. The next contraindication is active vomiting. This one is usually straightforward. A tightly sealed mask and active emesis are a dangerous combination. Vomiting significantly increases the risk of aspiration and can contaminate the mask, making continued therapy difficult or impossible. If vomiting occurs when is receiving CPAP or BiPAP, remove the mask immediately, clear the airway, and reassess whether non-invasive ventilation remains appropriate. The fourth contraindication is severe facial trauma. These devices rely on one critical factor: a good mask seal. Significant facial fractures, extensive burns, major soft tissue injuries, or deformities may make it impossible to obtain that seal. Without a proper seal, pressure escapes around the mask. The therapy becomes ineffective, and patient comfort rapidly deteriorates. In some cases, an alternative mask may help. In others, non-invasive ventilation simply isn't possible. It's also important to remember that contraindications exist on a spectrum. Not every patient fits neatly into a yes or no category. For example, a mildly anxious patient is not automatically a poor candidate. Many anxious patients do very well with calm reassurance and coaching. Likewise, a patient with mild confusion caused by hypoxia may become dramatically more alert after just a few minutes of effective CPAP, BiPAP. Clinical judgment is always required. However, there is one principle that should never be compromised. If you believe the patient cannot maintain or protect their airway protection takes priority over non-invasive ventilation. Never allow a desire to avoid intubation to delay necessary airway management. Our goal isn't simply to avoid invasive procedures. Our goal is to choose the safest intervention for the patient's current condition. That's why I like the statement across the bottom of this slide. When in doubt, don't mask. Protect the airway first. It isn't meant to discourage the use of CPAP or BiPAP. Instead, it reminds us that patient safety always comes with the device. The best EMS clinicians know when non-invasive ventilation is appropriate, and they also recognize when it's time to stop, change direction, and secure the airway before the patient deteriorates further. Recognizing when a patient is not a candidate for non-invasive ventilation is critical. But there's another equally important decision we must recognizing when a patient who initially responded to CPAP or BiPAP is now failing and requires us to escalate our care. One of the biggest mistakes we can make in respiratory management is assuming that because we've started CPAP or BiPAP, our job is finished. Non-invasive ventilation is not a one-time intervention. It's a dynamic therapy that requires continuous reassessment. Most patients who are going to respond will begin showing improvement within the first several minutes. Their respiratory rate begins to slow. Their oxygen saturation improves. Their work of breathing decreases. They become less anxious and more comfortable. If those things are happening, you're probably on the right path. But what happens when they aren't? This slide highlights several warning signs that should immediately make you reconsider your plan and preparing for escalation. The first warning sign is a worsening level of consciousness. Initially, many respiratory patients are anxious and restless because they're hypoxic or struggling to breathe. That anxiety isn't always a bad sign. It often means the brain is still receiving enough oxygen to recognize distress. What turns us is when that patient becomes progressively confused, increasingly lethargic, or eventually unresponsive. Those changes may indicate worsening hypoxia, severe hypercapnia, or simple respiratory exhaustion. Any decline in mental status should immediately raise the question, is this patient still protecting their airway? If the answer becomes uncertain, it's time to begin preparing for advanced airway management. The second warning sign is rising carbon dioxide. Whenever capnography is available, trend the ETO2 rather than focusing on a single number. A persistently rising EtCO2 despite BiPAP tells us the patient is continuing to fail ventilatorily. You may also know classic clinical signs of hypercapnia. The patient becomes drowsy. Their skin may appear flushed. They develop headaches, confusion, or increasing tachycardia. These findings suggest that respiratory failure is progressing despite therapy. The third, and perhaps most important, warning sign is respiratory exhaustion. This is the patient who has simply run out of reserve. You notice shallow tidal volumes. Accessory muscles are working harder than ever. The respiratory rate may initially climb into the 30s or 40s. Then something even more dangerous happens. The respiratory rate begins to slow, not because the patient is improving, but because they are physically unable to maintain the effort. It's a late finding. It's often the final stage before complete respiratory failure. When you see that progression, don't wait for apnea. Prepare your airway equipment while you still have time to perform a controlled intervention. One thing I always encourage providers to remember is that escalation doesn't begin with intubation. Escalation begins with preparation. Notify the receiving hospital early. Request additional resources if available. Assign airway roles within your crew. Draw up medications if medication-assisted intubation may become necessary. Verify your suction, laryngoscope, backup airway devices, and monitoring equipment. If the patient suddenly deteriorates, your team is already prepared instead of scrambling during a crisis. At the same time, continue reassessing. Not every patient who looks worse at first is actually failing. Sometimes a mask leak develops. Sometimes pressures need adjustment. Sometimes anxiety is limiting the effectiveness of therapy. Correct the simple problems first while remaining ready for the more ones. Ultimately, our goal isn't simply to apply CPAP or BiPAP. Our goal is to recognize whether it's working. If the patient is improving, continue supporting them. If they're plateauing, troubleshoot. If they're deteriorating despite appropriate therapy, don't allow non-invasive ventilation to delay definitive management. The best EMS clinicians aren't the ones who intubate the fastest. They're the ones who recognize the exact moment when it's time to move from non-invasive support to a definitive airway before the patient arrests. That's what good reassessment accomplishes. It turns airway management from a reaction into a deliberate, well-planned intervention that gives the patient the best possible chance for a successful outcome. We've spent time discussing how to recognize success, failure, and the need to escalate care. Now let's put all of those concepts into practice with a series of real-world EMS cases. As we work through these scenarios, don't focus on memorizing the diagnosis. Focus on identifying whether the patient's primary problem is oxygenation or ventilation, because that decision will determine your treatment. Let's begin with a patient many of us have encountered numerous times. You respond to a 72-year-old male complaining of sudden severe shortness of breath. As you enter the room, he's sitting upright, unable to speak more than one or two words at a time. He appears anxious, diaphoretic, and is using every accessory muscle he has to breathe. Your initial assessment reveals diffuse crackles throughout both lung fields. His blood pressure is 190 over 110. His respiratory rate is 28 breaths per minute. His oxygen saturation is 92% despite high flow oxygen. His EtCO2 is approximately 32 millimeters per, which is normal to slightly low. Immediately asking ourselves the question we've emphasized throughout this course. Is this primarily an oxygenation problem or a ventilation problem? The answer is oxygenation. The patient isn't retaining carbon dioxide. His EtO2 is normal. He's breathing rapidly and moving air reasonably well. The problem is that oxygen simply can't cross into the bloodstream effectively because the alveoli are filling with fluid. This is classic acute cardiogenic pulmonary edema. Our goal isn't simply to increase the oxygen concentration. It's to improve the environment where gas exchange occurs. That means recruiting flooded alveoli, reducing pulmonary congestion, decreasing preload and afterload, and reducing the tremendous work of breathing this patient is experiencing. This is exactly where CPAP excels. By applying continuous positive airway pressure, we begin reopening partially collapsed alveoli while pushing fluid back across the alveolar membrane. As more alveoli participate in gas exchange, oxygenation improves almost immediately. But CPAP is doing something else that's just as important. The increased intrathoracic pressure decreases venous return to the heart. That reduction in preload lowers pulmonary congestion and decreases the amount of fluid leaking into the lungs. At the same time, left ventricular afterload decreases, allowing the failing heart to eject blood more effectively. Very few EMS interventions provide both respiratory and cardiovascular benefits simultaneously. CPAP is one of them. As therapy continues, we should expect several positive trends. The patient's respiratory rate begins to slow. Their work of breathing decreases. Their oxygen saturation improves. The sensation of air hunger diminishes. Often, 2 minutes, the patient who was previously terrified begins speaking in full sentences. That rapid improvement is one of the most rewarding responses you'll see in pre-hospital medicine. Notice something else about this case. Although this patient is extremely sick, there is nothing here suggesting ventilatory failure. His carbon dioxide isn't elevated. He isn't fatigued. He's alert and protecting his airway. Adding BiPAP wouldn't necessarily provide additional benefit because ventilation isn't the problem we're trying to solve. This is why choosing the correct therapy matters. The right treatment isn't based solely on how sick the patient appears. It's based on identifying the underlying physiology. For this patient, CPAP directly addresses the problem. If applied early, combined with appropriate medications such as nitrates when indicated by protocol, CPAP frequently prevents progression to respiratory failure, avoids endotracheal intubation, and significantly improves patient outcomes before arrival at the emergent. This is exactly the type of patient CPAP was designed for, and one of the clearest examples of matching physiology to treatment. Now let's compare that patient with someone who looks just as sick, but for a completely different reason. This time, the problem isn't oxygen getting into the blood. The problem is carbon dioxide not getting out. The treatment changes because the physiology changes. Our second patient is a 68-year-old male with a long history of severe COPD. He complains of worsening shortness of breath over the past 2 days. Family reports he's becoming increasingly sleepy and difficult to keep awake. On your assessment, you hear diffuse expiratory wheezing with markedly prolonged expiration. Every breath appears to require tremendous effort. He's using accessory muscles, but despite all that work, his chest movement is surprisingly limited. His oxygen saturation is 94%, which at first glance doesn't seem terrible. However, his EtCO2 is 58 millimeters mercury, and he's becoming progressively drowsy. That combination should immediately. Unlike our CHF patient, this isn't primarily an oxygenation problem, it's a ventilation problem. This patient is moving less and less fresh air into the alveoli with each breath. Carbon dioxide production continues normally, but he can't eliminate it effectively. As CO2 accumulates, respiratory acidosis develops, respiratory muscles fatigue, and his mental status begins to decline. The drowsiness you're seeing isn't simply fatigue. It may be a manifestation of worsening hypercapnia. This patient doesn't just need oxygen. He needs assistance breathing. That's exactly why BiPAP is the preferred therapy. Remember the physiology we've discussed. EPAP keeps the alveoli and airways open, improving oxygenation and reducing airway collapse during exhalation. IPAP provides inspiratory pressure support, increasing tidal volume and helping the patient move a larger volume of air with every breath. The result is improved alveolar ventilation and more effective carbon dioxide removal. At the same time, BiPAP significantly reduces the work of breathing. Instead of relying entirely on exhausted respiratory muscles, the machine shares the workload. Every supported breath gives those muscles an opportunity to recover. As treatment continues, there are several improvements we hope to see. The respiratory rate begins to normalize. The patient's breathing becomes less labored. End-tidal CO2 gradually begins to decrease. Perhaps one of the most satisfying changes is the patient's mental status. As carbon dioxide levels fall, many patients become noticeably more alert and interactive. Family members often comment that the patient suddenly woke up. That's because you're correcting the underlying physiology, not simply masking symptoms. Notice something else about this case. Although his oxygen saturation is acceptable, his ventilation is failing. If we focused only on the pulse oximeter, we could easily underestimate how sick this patient actually is. This reinforces one of the most important lessons in respiratory care. Always treat the patient, not just the oxygen saturation. Where possible, combine pulse oximetry with capnography, respiratory effort, mental status, lung sounds, in your overall clinical assessment. For this patient, BiPAP directly addresses the primary problem. It improves ventilation, removes carbon dioxide, decreases the work of breathing, and often prevents progression to complete respiratory failure and endotracheal intubation. This is exactly the patient BiPAP was designed to help. The first patient needed help getting oxygen into the bloodstream. The second needed help removing carbon dioxide. But in the real world, patients don't always fit neatly into one category. Many have multiple disease processes occurring at the same time. Look at a patient where both oxygenation and ventilation are failing simultaneously. Our final case represents one of the more challenging respiratory patients you'll encounter in EMS. You're called for a 74-year-old male with a history of severe COPD, who has also been diagnosed with pneumonia over the past several days. Today, his family reports worsening shortness of breath, increasing fatigue, and progressive confusion. When you arrive, he's tachypneic, speaking only one or two words at a time, and appears exhausted. His oxygen saturation is 90%, despite supplemental oxygen. His ETO2 is 62 millimeters, indicating significant carbon dioxide retention. His respiratory rate is 26 breaths per minute, and although he's still breathing rapidly, every breath appears ineffective. This patient has both problems. His pneumonia has impaired oxygen diffusion across the alveoli, creating hypoxemia. At the same time, his COPD has caused airflow obstruction and air trapping, reducing ventilation and allowing carbon dioxide to accumulate. He's hypoxic, he's hypercapnic, and perhaps most importantly, he's becoming fatigued. This is exactly the type of patient where we have to ask ourselves which therapy provides the greatest physiologic benefit. While CPAP would certainly improve oxygenation by recruiting alveoli, it does little to help eliminate carbon dioxide. This patient needs more than oxygenation. He needs ventilatory support. That's why BiPAP is the preferred therapy. Remember how BiPAP works. EPAP functions much like CPAP by maintaining alveolar recruitment, improving oxygenation, and preventing alveolar collapse during exhalation. Meanwhile, IPAP provides inspiratory pressure support, increasing tidal volume and improving minute ventilation. That additional pressure support helps move more fresh air into the lungs and more carbon dioxide out. Essentially, BiPAP treats both components of this patient's respiratory failure simultaneously. As therapy continues, we're looking for several important improvements. His oxygen saturation should begin to rise as alveolar recruitment improves. His EtCO2 should gradually trend downward as ventilation becomes more effective. The respiratory rate should slow. Accessory muscle use should decrease. Most importantly, the patient should appear less exhausted. If the treatment is working, you often see the patient become more comfortable, more alert, and able to speak in longer sentences. However, this type of patient also deserves closure. Mixed respiratory failure can deteriorate quickly. If the patient's mental status worsens, if he becomes unable to tolerate the mask, if EtCO2 continues to rise despite therapy, or if respiratory effort begins to decline, it's time to prepare for definitive airway management. BiPAP is an excellent bridge, but it isn't a substitution when respiratory failure continues to progress. This case reinforces perhaps the most important decision-making principle of this entire course. Don't choose your therapy based solely on the diagnosis. Choose it based on the physiology. This patient has both oxygenation failure and ventilatory failure. Because BiPAP addresses both problems, it offers the greatest opportunity to stabilize the patient, reduce the work of breathing, improve gas exchange, and potentially avoid invasive mechanical ventilation. That's exactly why mixed respiratory failure is one of the strongest indications for early BiPAP therapy in the pre-hospital setting. We've now worked through three very different, yet each one reinforces the same principle. The correct therapy wasn't determined by the diagnosis alone. It was determined by the patient's physiology. Before we finish, let's bring everything together into a simple framework you can apply on every respiratory call. As we wrap up this course, I want to leave you with a framework that's easy to remember when you're standing in the back of an ambulance with a critically ill patient. The question is simple. What problem am I trying to fix? If the patient has an oxygenation problem, think CPAP. These are the patients with flooded or collapsed alveoli. They're moving air reasonably well, but oxygen can't efficiently cross into the bloodstream. You'll often hear crackles, see pulmonary edema, or encounter severe hypoxemia despite supplemental oxygen. CPAP applies one continuous level of positive pressure that recruits alveoli, improves gas exchange, decreases shunt, and often reduces both and afterload in patients with cardiogenic pulmonary edema. On the other hand, if the patient has a ventilation problem, think BiPAP. These patients are retaining carbon dioxide because they can't move enough air in and out of the lungs. They often present with prolonged expiration, wheezing, increasing fatigue, rising EtCO2, and eventually altered mental status. BiPAP builds on everything CPAP does by adding inspiratory pressure support. BiPAP increases tidal volume and improves carbon dioxide removal, while EPAP continues to recruit alveoli and improve oxygenation. Together, those two pressure levels reduce the work of breathing and provide meaningful ventilatory assistance. Of course, not every fits neatly into one category. Some patients, particularly those with COPD, complicated by pneumonia, pulmonary edema, or another concurrent disease, have both oxygenation and ventilation failure. In those situations, BiPAP is usually the preferred therapy because it addresses both physiologic problems simultaneously. But CPAP or BiPAP isn't the end of the assessment. It's the beginning. Once therapy is initiated, continue reassessing. Is the respiratory rate slowing? Is oxygen saturation improving? Is EtO2 decreasing? Is the patient's work of breathing less? Is their mental status improving or deteriorating? Non-invasive ventilation is incredibly effective, but only when it's producing measurable improvement. If the patient continues to decline despite appropriate treatment, don't hesitate to escalate care. The biggest lesson I hope you take away from today isn't simply knowing when to use CPAP or BiPAP. It's understanding why you're choosing one over the other. When you understand the physiology, the decision becomes much easier. So the next time you're caring for a patient in respiratory distress, don't immediately ask, should I use CPAP or BiPAP? Instead, ask yourself, is the primary problem oxygenation, or ventilation? If you can answer that question correctly, you'll almost always choose the right therapy. Move beyond treating numbers and begin treating physiology, and that's what ultimately leads to better patient outcomes. We've covered a lot of material throughout this presentation, and now it's time to see how well those concepts come together in real clinical decision making. Using your phone or tablet, scan the QR code on the screen to access a short 20-question knowledge check. These questions aren't designed to trick you. They're designed to reinforce the concepts that will make a difference when you're standing in the back of an ambulance with a patient who can't breathe. As you work through the quiz, think beyond simply memorizing facts. Ask yourself, what problem am I trying to solve? Is this primarily an oxygenation problem, where CPAP is the best choice? Or is it a ventilation problem, where additional inspiratory support that only BiPAP can provide? Remember, choosing the correct therapy begins with recognizing the underlying physiology. Pay close attention to the patient assessments and scenarios. Look at respiratory rate, oxygen saturation, EtCO2, lung sounds, work of breathing, mental status, and the overall clinical picture. Those findings should naturally guide you toward the most appropriate intervention. If you miss a question, don't think of it as a failure. Think of it as another opportunity to strengthen your clinical reasoning. The goal isn't just passing a quiz. It's developing the confidence to make the right decision quickly when your patient is depending on you. Take a few minutes to complete the quiz.